So we're going to be diving into some edentulous soon. Keep going? Okay. So, edentulous. Everybody wants to know about edentulous, and I'm going to make a comment here. Because you should be guiding every implant. And if you think the only thing you're going to do with this is guide edentulous, you haven't gotten the picture. Because edentulous gives everybody a hard time with everything they do. This is complex surgery, and we just make it easier. But it's still complex. We remove steps, but it's still complex. So once you get good at guiding all your implants, then you dive into the complex cases. I used to talk to people who would say static guides don't work. I've tried them in the full arch cases and they don't work. And I said, well, how many simple cases did you do? I don't use it for simple. Well, of course it doesn't. You don't start doing, maxillofacial osteotomies when you start as a resident. You start pulling teeth and you move up gradually. With guided surgery, you learn the tool, you learn how to use your scalpel, and then you use it for complex stuff after you've mastered the technique. And it's not just about you, it's about your team. So, edentulous. Right now, you have to start by putting in screws into the patient, we call them edentulous fiducials, before you take your CT. Why? Remember we talked about the dynamic reference frame. You have to see an object inside the CT in order to register your patient. Well, you don't have the ball bearings, right? When we go to fiducial-free registration, which we're there, you won't need these things, but you're still going to have to touch something anatomic that's fixed. So we start now with 5 little 1.5 millimeter screws, and I'll show you how we do that. Then you do a dual scan. You have the patient's denture. You put the fiducials on the denture, you scan the denture. Then you put it in the patient's mouth with the fiducials on it, you scan the patient. You then import the patient's CT, and then you import the patient's CT of the denture. The software automatically superimposes on you. It also finds the screws for you. And then you plan your case. Then you expose the fiducials. You place the tracker, and I'll show you what that is. It's a little plate. And then you register the patient by touching the plate with the probe. And then you place your implants and you take everything out. Now, I'll tell you how I do this now. I do it all on the same day. I don't take the x-rays ahead of time. Someone last night at dinner said, well, in my practice, patients won't let me put the screws in ahead of time. If I say I'm going to put screws in, they won't let me do the case. Well, I said, why would you tell me you're going to put screws in? You're going to take them out. And if you're going to do bone grafting or tooth extractions beforehand, because if you're a mutilated dentition, you put the screws in when you take the teeth out or you do the bone graft. So why do you even have to talk about it, because you're going to take them all out? I'm not saying you can't, you can. But it's up to you. So these are the screws you use. They're little tiny screws. You have to use these specific screws. And you put them in around the area that you're going to expose when you put your implants in. Well, people will say to me, I don't make incisions when I do fully edentulous cases. I drill through the soft tissue. Well, I would say then you're probably not doing good surgery, because what's it about? It's about the soft tissue. You want to maintain your soft tissue. And if you drill through that 2 or 3 millimeter piece of soft tissue, attached tissue, you destroy it. So I lay little flaps in almost everybody to preserve attached tissue. In the cases that I don't, in the posterior maxilla, you don't have to make incisions. You can still do it the same way. But most of the time, I'm doing these terminal dentition cases. So this is the classic case I got. And I think this addresses your question from before. What do you do when the occlusion's messed up and the teeth don't have anything to do with where you're going? Now, you have to know how to make a denture in order to do full arch cases, right? And it doesn't, you still have to follow good prosthetic principles. So in a case like this, do you want to take out all the teeth at one time and mess with the vertical and the incisal ledge and the midline and everything in two different arches at the same time? If I'm working with a guy like Progobin or Sullivan or one of the prosthodontists that's really good, I'll do it. But they don't want to do it because they know better. It's so much more complex. So what do we do in a case like this? We slick all the upper teeth and put them in a denture. Typically, at the beginning, and we put in an immediate, and we establish our vertical, we establish our midline, we get our phonetics with one arch, the maxilla, because it all starts with the maxilla and the incisal edges. So when I take the teeth out up here and I bone graft this, I put my screws in up here and down here. Okay? Does that make sense? And I don't do any extra surgery. This is the way I was going to do it anyway. It doesn't have anything to do with dynamic versus static guidance. Now, if I was going to do both arches at the same time, it'd be a different story. But I don't do that if I don't have to. So I'm going to fabricate an immediate denture. I'm going to extract the maxillary teeth, do my bone grafts, and place the fiducials in the maxilla. I make just enough incision to do my grafts. I don't make big incisions. And in the mandible, I'm going to put the fiducials in. I make no incisions. I take a 15 blade and I make a stab incision and I screw the screws stab incision. It's 2 millimeters in size. Patients don't even notice it because they're so sore in the maxilla. And even if I was going to do a case and put those screws in ahead of time, that's the way I do it. I give them a little tiny local, I make a stab incision, and I screw the screws in. They're self-drilling, self-tapping screws. So after I've taken these teeth out, we adjust the remaining mandibular teeth. You can see I tried to put an X clip in here. It wouldn't register on the CT, which means these teeth are so mobile that I can't use them. So it's going to be fully edentulous down here. So after I'm going to do an extraction, implants, and immediate hybrid in the mandible and the maxilla afterward. So there we are. I'm taking teeth out, grafting, and putting the screws in as I move around. You can see I've put the membrane over here. I haven't put a membrane in yet here. I'm putting the screw in. Just screw it in. You see how I'm keeping it high up? The reason I'm keeping it high up is so I can find it. I don't want to put it way up in the vestibule, and I don't want to make big incisions here anyway. I'm just taking old teeth out and grafting. And you can see I put them in the mandible. So let me show you the mandible. That's the maxilla. This is the post-op. You can see I put them in the mandible, and I'll show you. This is putting them in the mandible. Now there's just a little stab incision here, and then I just screw it in, and you can see where they are. Now the reason I put in more than 5 is because sometimes you can't find the damn screws. Okay, or say a patient knocks a screw loose. You only really need 3 screws, but we tell you to put 5 in, but I'll put in more. And they're all really near the top of the incisions because I don't want to make big incisions. Now, if you're planning and a screw's in the way, what do you do about it? Nothing. You don't need to worry about it because once the patient's registered, the screws aren't necessary anymore. So the screws really are not a big deal. So here I am doing a dual scan. Now, you see this. I import this. And I'm going to follow straight across. I'm showing the workflow. I import the CT. This is going to be in a mandible case. Now you see the blue dots? The software finds the screws. The next thing you do is I'm going to map the nerves. And then I'm going to import the CT of the denture. And it registers and it plops it in. I also took an intraoral scan of the patient's upper partial just for planning purpose. You don't have to do that. And I used this superimposition screen to superimpose the maxillary teeth. Now, when I plan, what I do is I start with a virtual implant in the midline of the mandible. I make it 2 millimeters, and I make it really long so I can see where it is relative to the midline. You see the genotubercles there? And I establish my ideal vertical and how I want all my implants to be, because I'm going to make them all parallel to that. This is a nice pearl about treatment planning. Find the midline. You're not going to put an implant there, but all my other implants are going to be aligned with this tool over here to that implant. And you can put those implants in really fast. You're just going to put in 5. You just plop the 5 in and put them into about the height you want, and then align them. So here I've told the software where it is. It's a mandible. It's superimposed. And now I go ahead and I plan my implants. In this case, just 2 implants. I use the align tool down here. These implants are perfectly parallel. And now what you have to do is make sure that these screws are indeed screws. If you have a piece of metal or something else is picked up and it's not a screw, you just hit the X button. Whichever screw is highlighted here will be yellow inside the software on all these different images. And you check and make sure they're screws. Now you calibrate your handpiece. And then you calibrate the probe. Now, why are we using a probe? Remember what I told you about the chuck and that there's slop in the chuck of your drills? When we first started doing that, we thought, well, we'll just use the drill. We didn't know about the 400 microns. We hadn't noticed it. Nobody had ever talked about it. But if you multiply 400 microns times 5 screws, that's 2 millimeters of error you've just introduced. So the probe is rigid. Now that probe is going to be used for other things in the future. So you just hold the probe. There's a divot in the plate, and you hold it. And you just hold it in front of the. Make sure that the probe is touching the plate at all times, and you just move it around, and it's calibrated the same way. There are 2 different patterns. The probe has a probe tip on it. Make sure you use the right one. So we're now going to put this little plate on the mandible or the maxilla. That is how you rigidly fix your tracking device to the patient. They're self-drilling, self-tapping screws that fit into the same green screwdriver you saw before. You attach the arm beforehand. It's a nice little handle while you're screwing these little screws in. These are the screws that come with it. There's a 2 millimeter diameter and a 2.7. And then there's a bunch of different lengths. Most of the time I ended up using the green ones. This is what the construct looks like on a model. And there it is in a patient's mouth. And these take me about 10 minutes to put on. And I show you this case because people say, well, how do you put it on an atrophic mandible? This is like one of the worst cases you would want to do, because there's 6 millimeters of bone in the body left in the angle here. And I show you, I see the holes where I put the screws. You can see the screw holes. You just hold it in. You're holding that little black arm, and you just screw them in. And it's rigid. And then you attach the tracker, and you touch each one of the screws, and you press this button. It says register. When you're touching the screw, you press the button. It takes 3 seconds to register. After you've gone through 3, it starts tracking. If you happen to go out of order, it doesn't matter. You just go re-register it, and then you place your implants. Now, remember I told you that the more you guide, the more accurate you are. Look at these numbers, 4 and 5. What happened? Now look at the implant that's placed there. It's a tissue level, right? Now what did I forget to do? I forgot to guide my countersink. And the thing flares out, And when I screwed it in, since I didn't guide it, the back of the bone pushed the implant. If I had guided my countersink, it would have been on. But I didn't. I made a mistake. I'm human. Remember I said the more humans involved, the worse it is? If we could just figure out how to get the surgeon out of the equation. So we've timed a couple of cases. I've been timing them. What do I do now with like I did a case of like an 83-year-old guy a couple of weeks ago. And I'm not going to show you a case because I haven't finished it yet. But I know how long it takes me. And I typically put, for a hybrid case, an all-on-4 and all-on-5, about 2 hours aside. Okay? I'm putting in 2 hours and 15 minutes aside now because I'm going to do everything on the same day. I'm not going to put screws in ahead of time. Those patients don't want more than one surgery. So this is what I do, and these are the times it takes. I'm going to take these teeth out, take the bone off, and put the implants, in this case just 2 implants, and do it all the same day. So I give the patient local, take the teeth out, do a little plastic, takes 12 minutes, reline that, take a CT of that, the screws are in, then I put that in a patient's mouth and take a CT. So nothing's taken too long so far. I planned the case, took me 15 minutes. Why? And she's watching me the whole time. I couldn't find the nerves because her mandible's so atrophic. So then I calibrate the instruments. I put the tracker on. It took about 10 minutes to put the tracker on. I register the patient another 10 minutes, and I place the implants. Now, I know how long it takes me to place an implant. A small diameter takes me 5 minutes because there's only 2 twist drills, and a large diameter takes me 12 minutes because there's more twist drills. So if this had been an all-on-4 case, 5 times 4, because I was using 3 implants on her. So there's only 2 twist drills. So you can multiply it out. How did I do this time? I guided everything, and I used a different kind of implant. Under 2 degrees, 7.8. Under 2 degrees, 0.4, 0.9. Now, if you think about it, this is more rigid than an X-clip. So we have the potential for this to be more accurate than an X-clip. It's more complicated, but it's more complicated cases. So this can be more accurate than dentate cases. It's an important thing. So let's look at the first case I ever did. This is for the FDA. This is a failed implant case. This is a very complicated case. There used to be implants there. Used to be implants there. And this is a young woman. She's 39. This is the way she shows up. Now, this is the temps that we're in. Now, you wonder why they failed. I can look at, how do I judge a restorative doc? I judge them by their temps because they're going to be thrown away. And if they make lousy temps, I know they're lazy. They might be talented, but they're lazy because temps are used to plan your case. They're how we develop soft tissue. They're how we develop aesthetics. They're supposed to be duplicated. I see that. I know why all those implants failed. That implant's coming out. There's another implant here. It's marginal. So I do a big graft. I got a new temp made by a new dentist. This is a restorative Dr. Lievino. Big graft. Now I would put the screws in now. I didn't do that then because this is the first case I ever did. So there's my post-op reconstruction, plenty of bone. But I know that bone's not the best quality bone. I don't care who you are. When you do these particular grafts, it's mushy bone for about 9 months, right? So we wait 6 months, and I put my screws in just with stab incision. That's all I do, a little local and a stab, and I can see I put them all the way around here, put them way around. And you can see they go into the graft, got nice graft results. And then I plan the case. Now you can see where I'm putting the X-clip. Now I could easily have put in, the E-clip, or the plate. I could have easily put the X-clip on the temps. But this should be more accurate because it's more rigid. And that's where I did it. I put the X-clip up front between these roots. It was real easy to put in. And I put in a lot of implants. Why did I put a lot in? Because I'm always afraid in these mushy bone cases that I'm going to get failures. Okay, so I over-engineer. I don't charge the patients once I get to 6. I don't charge them extra for them. I'd rather make them happy, make sure everything's redundant, and get a good result. Now, this is my mean. Now, this is different. This is global. When we say global, we include depth. Anything below 1.4 with global number, because it includes depth, is the same numbers you've been seeing. The reason I don't show you global numbers is because they're harder to understand. Because there's three-dimensional numbers that include depth. I've been showing you entry and apex because it's easy to understand the lateral movements. But when you start throwing in depth in those numbers, they get confusing. But these are actually under a millimeter in entry and apex. So there's the provisional at 6 months. And you can see it's beautiful. This got a connective tissue graft since then. And, excuse me, this is the final. And she got a connective tissue graft there. I wish I'd taken that out. So that was the first one we ever did. You could have done it on the provisionals over here. Now let's look at a rocking case here. That is a full arch crown and bridge case that's just nothing but caries underneath it. There's nothing but caries under this. The patient takes it out and puts it in a cup with posts in it next to her bed when she goes to bed at night. Okay? This has already been done. I already did this case with hybrid, immediate. She came in from a restorative doc, the same guy you just talked to. Excuse me, this is Sullivan's case. He's got a CT scanner. And you can see it looks a little different than mine because it's not an ICAT. And I'm just using this for my consult to see if I can do an immediate on this patient. And she's got enough bone, so I can take the teeth out and put the implants in, and I'm going to do it all in the same day. I'm not going to put screws in ahead of time. All right? So my plan is to take all these out, put the screws in, and put the little plate on up here, and then she's going to go and get a hybrid the same day. Now, how do I image this? I can't put an X-clip on, but I can take an intraoral scan, but it's mobile, right? So I'm going to scan her ahead of time to get occlusion. And when I take her CT, I'm going to have her in occlusion because I can close her up. Because there's no X-clip in there. So there is, you see the screws are in here. See the screws up here? So this is how I'm planning the case. I took this ahead of time so I can use the occlusion of the bottom to make sure this is all in the right place. So you can see I'm planning the implants. See the screws here? The software found the screws. So I'm planning this. I superimposed it. And you were asking about artifact. Get all that metal from that great big splint in there that I took, which was in the mouth for the CT. But it's gone, isn't it? It's because I don't need it. I just took a lasso and lassoed the entire CT out of the way. And I planned with everything in the 3D, in the 2D views. And now I'm going around and I'm planning the case. And I can turn on and off the STL files at will to check the occlusion. And now I'm going to go choose the edentulous fiducials and make sure they're the right place. And if the STL file gets in the way, I just turn it off. So now what I'm going to do is I'm picking each one of the fiducials, and then I'm going to calibrate the handpiece, and I'm going to calibrate the tracker. And now what am I doing? I've got the tracker in place, and I'm touching the screws. See the screws? Now, I didn't make a gigantic incision here. I just made an incision big enough to take the teeth out and see the edge of the alveolus, because I don't need to do a big bone reduction in this case. So I want to do as minimal incision as I can. And you notice the teeth aren't out. And I've started, after I calibrate, I'm going to start placing implants out here and move around. I don't need to take all the teeth out to put an implant in. I just take them out as I'm moving along and I reduce bone. So I'm just moving across the arch like this as I go. And I can take the screws out too, because I don't need them once I've registered the patient. So you can see I'm touching the screw. See that? And you see the probe is bent. That's an important point. When you look at other systems, they say our parts are pre-calibrated. That means you don't need to do calibration, so that makes it easier, right? Well, it's great until you drop it. I've dropped that probe more than once. I don't know about you, but I drop things. And it doesn't make any difference because I'm going to calibrate it at the time of surgery, right? I calibrate all my instruments at the time of surgery so that I never have to worry about a damaged instrument. So now I'm placing my implants, okay, and there's my result. That looks great. And there she is, post-op with her hybrid conversion. So now she's hybrid to hybrid. Okay, let's look at a really crazy case. This is the last edentulous I think I have. I think we're almost done here.
5 minutes.
Yep. So, this patient is special. All I want to do is get her enough room down here to get her teeth back. So what I'm planning on here is 2 mini implants. I'm going to engage 2 mini implants and that tooth for my X-clip. And I'm going to do it all in the same day like I've showed you. You saw how fast I can plan a case. This is 5 implants. It doesn't take me long with that align tool. So she gets pre-op hyperbarics. Okay. Now, how am I going to do a dual scan when she doesn't have a denture on the bottom? How am I going to plan my occlusion? I can scan her maxilla, and I can put her denture in her mouth for her CT. Okay? Now, there's going to be an X-clip in the way, but it'll be at least close enough that I get an idea. Plus, I have her old teeth. So she gets the hyperbarics, and she's going to get a post-op. So I'm going to take a CT with the maxilla with fiducials on it. I'm going to place the mini implants with no incision. It's blind. I got to do it freehand. I'm going to place the X-clip on the mini implants on the one tooth. I'm going to take a CT, do the dual scan on the opposing arch. I'm going to load the scan of the patient. I'm going to define the arch, import the DICOM of the maxilla. I'm going to define the nerve, plan my case, calibrate my drill, calibrate my X-clip, and place my implants, and then remove the mini implants. I'm not going to make any incisions in the posterior. Just use these. I happen to have these from years ago, these 3M things. And that's where I'm going to plan on doing them. And I actually did do a little study on this. We didn't publish it because we really don't want people to do this unless you have to. Because it's going to rock, isn't it? I've already showed you they rock. So the only person that should do this is somebody that understands what? System checks. Because you're going to be doing a ton of them. And if I used bone reduction guide, what am I going to test on? I just wiped the bone out. So when I tell you I take out teeth, take out the bone and put in an implant, take out teeth, and I just move along the arch, I use the adjacent bone and teeth for my system checks. So you don't really need to do bone reduction guides. And in a way, they make it worse. Or don't remove all the bone. You can just take the bone down as you go along. And if it's really deep and it makes you fearful to drop a drill in 5 millimeters past the top of the drill, then reduce a little bone. And then drill. Does that make sense to everybody? So So a lot of the things that you think you need to do, you've been doing them because you were forced to do it by the old systems. And they weren't done for any other reason as a compromise so that you could use the restrictions of their systems. Okay? So here's the implants, the mini implants, no incisions. This is what I think mini implants are good for, nothing else. I wouldn't put a mini implant in anybody because I take so many out. So the X-clip is going to be on this tooth and these. I'm going to do the dual scan on the denture. I'm going to import the patient, import the denture, tell it what it is. It's registered. And then I've done this, define the arch, import the denture, define the nerve, plan the case, calibrate the handpiece and the X-clip. Now I'm going to extract the teeth as the implants are placed and use the teeth and the bone for system checks. Then I'm do a lot of system checks, place my implants, and then remove the mini implants. I'm going to do one implant freehand, the one that was underneath the X-clip. Now I've actually taken cases and I've cut a chunk of the X-clip out of the way when I had teeth proximal. Okay? I've done that, but you can't do that here because those mini implants don't really hold it very well. And this is the patient, and you can see I'm doing lots of system checks, and I'm starting out distally, far away from the X-clip, because that's the hardest one, because that's the farthest away from the X-clip, and I got bone to check it on, and then I move around the arch. And I can use these teeth for system checks too. So there we are. You can see I didn't touch the bone back here, right? And you can see my pointer's wearing out. If we have another pointer, that'd be great. I have one in my briefcase. Thank you, sir. I wore this one out. So I sent this to the dental students that were from Brazil that came in and I do that study on. And one of them's in Perio grad school now. And he asked, he's really into the X-Guide, you can imagine. And he asked me to send him some cases for presentation. And I sent him this one. I said, I promise you nobody else is going to show you this. It's going to show this. And he says to me, do I have to turn this guy on? Thank you. I don't need the other part. So he says, oh, you put this one in wrong. Well, I really didn't put that one in wrong. That's the one that's right. That's the one I planned. I put this one in wrong. Remember when I said freehand? And every time I put an implant freehand now, I always do pre- and post-op superpositions. And guess what? Consistently, they're the worst implants. Over and over. Because I hardly ever put in freehand implants. So let's see how I did. Now this is on probably worst case scenario. These are all the guided ones. My mean angular was 2.4. My platform deviation is 1.2. My apex is 1.6. Those are as good as you saw in those static guides. They're better, right? They're better numbers. They're probably not statistically significantly better. There's not enough of them anyway to do that, but you can see those are fantastic for an edentulous case. One implant freehand. I'm off 9 degrees, 2.8 on the platform, 1.7 at the apex, and 3 on depth. Only one freehand. Now this is a hard case, but it's not anywhere close to where I planned it. So there she is. She's loaded at 4 months. Everything, I'm happy camper, right? Well, everything does not always work out well in life. Look what happened. You remember you could hardly see where those mini implants went in? She's developing osteoradionecrosis. Yeah. It's like, oh my God. She's a really nice lady and she knew what she was getting into, but this breaks my heart. So what do I do about it? I dive her, and then I'm going to do a little tiny sequestrectomy, and This is this is a microscope, and I'm just going to go in and remove as little bone as I can to stop this process. And I stick some PRF in there, right? I'm going to put a little PRF in there. And then I dive her, and now she's 2 months out, and you can see I just removed a little bit of bone, but can you imagine if I had laid a flap back there? Everything that you wouldn't want to happen would have happened, okay? So right now it looks good. I just told her to go see her restorative doctor to finish her up. So here's a case, an edentulous case, that incorporates everything you've seen today. The X-clip, you've gotten the concepts of bone reduction that I talked about, is that you place the implant and just slowly remove them as you go around because you actually want that bone. And you know how much bone to reduce because you've used the dual scan and you want to be at least 15 millimeters from the incisal edge. So that's where you plan your implants. So you really don't need a bone reduction guide. If you want one, you can. So this one is when an E-clip is contraindicated, you can use mini implants if you have to. But this is a strange case. Dual scan the opposing arch when you do that. When you're using mini implants, you've got to be really careful with system checks. So it's break time. Yeah. So we're going to go through the extended indications and off-label stuff as the last. Are there any questions?
Yeah, is there any thing we should be careful about when we take cone beam CT with S-clip, or when we do the E-clips? Anything?
Well, you don't need, with the E-clip's not in, the plate is not in the patient's mouth when you do an edentulous. When you take a CT, I think it's important that you get the, in dentate cases, that you put a cotton roll in so that you can see the soft tissues. You don't want the patient biting on the X-clip, because if they're biting on the X-clip, putting pressure on it, they're going to move it. And when you put it back in, they won't be biting on it. Does that make sense? So if you have a really loose X-clip, you either need to put a little bit of composite on it, like short clinical crowns. That's what I do. And it doesn't take a minute. So, yeah. So that's about the only thing I can add. Can you think anything when they're taking a CT? It's certainly easier than the old protocols with some of the guide systems. I don't know if anybody ever use the Siemens, or not the Siemens Sirona system? I mean, it's crazy how complicated their CT scanning stuff is.